Okay, good afternoon, dear students. We continue our lectures in propedeutics, and today we start talking about blood. We talk about hematology. And we start from bleeding disorders. So we'll talk about hemostasis and typical bleeding disorders. So, hemostasis is a complex process depending on interaction between the vessel wall, platelets, and coagulation, and fibrinolytic mechanism. So, if you cut your finger, if I cut my finger, what happens? Why bleeding stop? We have three mechanisms to stop bleeding, to avoid losing blood. This is vessel wall properties or features of vessel wall. This is platelets or thrombocytes, and this is coagulation and fibrinolysis. First, vessel wall. The vessel wall is lined by endothelium, which in normal conditions preserves the circulation by preventing platelet adhesion and thrombosis formation. Injury to vessels causes reflex vasoconstriction, while endothelial damage results in loss of antithrombotic properties, activation of platelets and coagulation, and inhibition of fibrinolysis. So what happened, first, what happened in case of damage of our tissues, and you know that all tissues filled with vessels. First, what happened, we have constriction of vessels, and the result, bleeding decrease. And next, what's happened, damage of the vessel wall, damage of endothelium, result in activation of thrombocyte adhesion and coagulation. Platelets. Platelet adhesion to collagen is dependent on platelet membrane receptors. Following adhesion, platelets undergo a shape change from a disc to a sphere, spread along the subendothelium, and release the contents of their cytoplasmatic granules. So, if to say actually easier, what happens? If you again cut your finger, first stop of bleeding, which happened during few minutes, depends on activation of platelets. What platelets do? Platelets with their own bodies just plug the vessel, damaged vessels. What activates platelets? When we cut our fingers, we cut our tissues, or surgeon cut someone's tissues, endothelium damaged, and collagen, which we can have a lot of collagen in vessel wall, and when collagen becomes reachable by platelets, these receptors on platelets, when they feel collagen, they start activating, and thrombocytes come together and just plug the damaged wall with their own bodies. And as a result, we have formation of white thrombi. We call this adhesion of thrombocytes. We call this white thrombi because it has white color. And this is just bodies of thrombocytes. Again, remember that primary stop of bleeding depends on thrombocytes. And that's why such parameters or analysis and as time of bleeding depends on thrombocytes. And of course, then thrombocytes release some substances which activate coagulation. Coagulation and fibrinolysis. Coagulation, this is final stop of bleeding, because you know that result of coagulation, this is formation of fibrin. In our blood, we have fibrinogen. This is short, small molecules. But in case of activation of coagulation, result of such coagulation, this is formation of collagen net, of fibrin net, which actually consists of small molecules. They come together, they touch each other, and the result we have fibrin clot. We have fibrin clot. And this clot, known as red thrombi. Why red thrombi? Because during formation, this net made from fibrin just catch erythrocytes which present in blood. And the result, we have some net, three-dimensional net filled with erythrocytes. And the result, such thrombi has red color due to due to erythrocytes. Red color due to erythrocytes. And you know from biochemistry about coagulation cascade. Coagulation cascade involves a series of enzymatic reactions leading to the conversion of soluble plasma fibrinogen to fibrin clot. And coagulation factors primarily synthesized in the liver. Again, coagulation is a very complex process, complicated process. It has few stages, and you know about coagulation factors. The coagulation factor, this is mostly specific proteins which produced by liver. And that's why in case of liver disorders, we may also see some kinds of bleedings, just because coagulation factors produced by liver. Again, this is coagulation cascade. You know that a lot of coagulation factors we have. No, first, you know that number one, this is calcium, because without calcium, we don't have coagulation. But then actually we have other proteins, mostly enzymes, which actually activate one another. As a result, we have some steps, step-by-step formation of collagen, of fibrinogen clot. Now, at least we can actually detect or name three steps or three levels or three parts of such cascade. First, this is formation of thromboplastin. First, this is thrombation of thromboplastin. Then, prothrombin change to thrombin, and activation of thromboplastin, prothrombin change to thrombin, and then thrombin activate fibrinogen, and fibrinogen change to fibrin. So three actually again stages. First stage, this is formation of thromboplastin, formation of thromboplastin. Second stage, this is formation of thrombin. And third stage, this is formation of fibrin. And we have a lot of factors, at least 13 coagulation factors. Even absence or deficiency of one lead to problems with coagulation. That's why we have a lot of coagulational disorders, because again, we have a lot of factors. One absent, one decreased, we have a problem. So, if you have a patient with bleeding disorder, what you should ask, what questions you should ask? First, is there a generalized hemostatic defect? Meaning what? Supportive evidence for this includes bleeding from multiple sites, spontaneous bleedings, excessive bleeding after injury. So if we have generalized hemostatic defect, we have multiple sites of bleeding. It may be nasal bleeding, rectal bleeding, it may be men's bleeding, so excessive bleeding after injury. So all this tells that this is generalized hemostatic defect. Then this defect inherited or acquired, because sometimes some bleeding disorders inherited, some bleeding disorders acquired. Now, family history of bleeding disorder should be sought. Severe inherited defects usually become apparent in infancy, while mild inherited defects may only come to attention late in life. For example, with excessive bleeding after surgery, childbirth, dental extraction, or trauma, some defects are revealed by routine coagulation screen tests, which are performed before surgical procedures. So again, inherited, acquired. Ask patient about his relatives, ask about his grandfathers, especially if we talk about coagulation disorders. And family history of bleeding disorders usually tell us about inherited problems. If it's happened in childhood, also usually tell us about inherited problems. Is the bleeding suggestive of vascular platelet defects or coagulation defect? Again, bleedings may be due to different problems. Again, it may be problem with vessels, it may be problem with thrombocytes, it may be problem with coagulation. I told you about three mechanisms of actually bleeding stop, and we may have problems in each element of this system. That's why bleeding may be due to vascular platelet mechanism or due to coagulation problems. Vascular platelet bleeding, characterized by easy bruising and spontaneous bleeding from small vessels. Easy bruising, spontaneous bleeding from small vessels. There is often bleeding into the skin. Now you know that easy bruising, you know, of course, if you beat yourself or someone beat you, you may find blue and black marks after some time. This is result of bleeding into the skin, and this is normal. Then it's disappear. But if the same blue and black marks appear without actually beating, just because of touching, sometimes patient even can't understand why it's appear. In this case, we talk about easy bruising syndrome. Easy bruising syndrome. We use term purpura. We use the term purpura. Purpura includes both petechia, which are small skin hemorrhages varying from pinpoint size to a few millimeters in diameter, and which don't blanch on pressure, and ecchymosis, which are large areas of bleeding into the skin. Bleeding also occurs from mucous membranes, especially nose and mouth. Again, when we talk about purpura, in case of bleeding, it may be petechia. Petechia, this is small red spots. Just imagine small red spots, you know, as after insects bites. Just imagine some mosquitoes, insect bites, and we have some red spots. The same may happen in case of platelet or vascular disorders. And also we talk about ecchymosis. Ecchymosis, this is big actually hemorrhages into the skin, also known as blue and black marks. Coagulation disorders. Coagulation disorders typically associated with hemarthrosis, muscle hematomas, bleeding after injury or surgery. There is often a short delay between the precipitating event and overt hemorrhage or hematoma formation. So in case of coagulation disorders, usually bleeding much more severe. In case of coagulation disorders, usually patients suffer from hemorrhages into joints, hemarthrosis, so-called. This is accumulation of blood in joints. This is hematoma. Hematoma, this is bleeding into muscles, and sometimes up to half a liter of blood may be found in such hematomas. Bleeding after injury or surgery. A patient has some small trauma and blood can't stop. Bleeding. Actually, patient with hemophilia, which is coagulation disorder, may die after teeth extraction. We just imagine the dentist remove his teeth. Okay, this is small wound. Usually what happens in 5-10 minutes, bleeding stop. In patient with hemophilia, this bleeding never stop, and patient may lose all his blood through this absent tooth. Usually delay between precipitating event and overt hemorrhage. What's happened? Remember what I told you, that in case of damage, first what happened? This is formation of white thrombi. This is aggregation of thrombocytes which close the hole, close the injury. And after that, at the same time, we have activation of coagulation, because coagulation usually needs minutes, at least 5, 6 minutes to produce red thrombi, And at that time, thrombocytes disappear. They again disaggregate and disappear because now we have strong and very good red thrombin. What happened in case of coagulation disorders? In case of injury, thrombocytes normal absolutely, and they formate actually white thrombin and bleeding stop. Then thrombocytes wait 5 minutes. They believe that next what should happen? Red thrombin formation, and they disappear. But no red thrombin formation because we have coagulation problem. As a result, bleeding starts again. And that's why patient with hemophilia after tooth retraction, the removing of tooth, after a few minutes, bleeding stop, everything okay. But then 5-10 minutes pass and bleeding starts again and can't stop. So laboratory investigations in case of bleeding disorders. No, first of all, blood count and film show the number and morphology of platelets and any blood disorder such as leukemia or lymphoma. So you know that we have a lot of platelets, 150 to 400 10 times 9, it means billions per liter. 10 times 9, this is million. 10 times 6, this is million. 10 times 9, billion. You see that number of platelets, how many times? 40 times more than number of leukocytes. Of course, it's less than number of erythrocytes, but more than number of leukocytes. And in case of platelet disorders, so-called absent or decreased number of thrombocytes, thrombocytopenia. Thrombocytopenia, this is lack of thrombocytes. Number of thrombocytes decreased. Next, bleeding time. Bleeding time. Remember I told you that primary stop of bleeding depends on platelet action. That depends on platelet action. And that's why bleeding time tells us about activity of platelets. Activity of platelets. Now, there are different actually methods to detect bleeding time. Now, for example, applying a sphygmomanometer cuff to the arm and inflating it to 40 millimeters hydrogel. Then 2 1 millimeter deep and 1 centimeter long incisions are made, no special device, in the forearm with a template. Each wound is blotted every 30 seconds and time taken for bleeding to stop is recorded. Normally between 3 to 10 minutes. Again, idea is following. We have small wounds and we just apply some cotton, just watching bleeding continue or not. And normally bleeding should stop from 3 to 10 minutes. Also, we use actually bleeding time by Duquet. Bleeding time by Duquet, idea the same, but we use our ears. That make punch of air using special steel device and then see how soon blood stop. That usually takes by Duquet from 2 to 4 minutes. That just we apply cotton, see actually how soon bleeding stop. Again, remember please that bleeding time depends on platelets. And even in patients with severe hemophilia with coagulation disorders, bleeding time absolutely normal because primary stop of bleeding depends on platelets, on thrombocytes. And prolonged bleeding time found in patients with platelet function defects, and there is a progressive prolongation with platelet count less than 80, 10 times 9. And the bleeding time should not be performed at low platelet counts, low platelet counts. Coagulation tests. Again, bleeding time, we can check platelets, how they act. Now coagulation tests. Coagulation tests performed using blood collected into citrate, which neutralize calcium ions and preventing clotting. So coagulation tests. Coagulation tests we perform to detect problems with coagulation, with formation of red thrombin, And to do all these tests, first what we should do is to collect blood. But the problem is, when you collect blood, blood immediately coagulates, because this is activating of coagulation happens when blood leaves vessels. And that's why to prevent coagulation, we add citrate. Citrate remove calcium ions from plasma, but without calcium, no coagulation. That's why we can just bring this blood, citrated blood, to laboratory and perform some tests. Again, blood collected into citrate, which neutralize calcium ions and prevent clotting. Then we can take this blood, then we can centrifugate, remove erythrocytes, and do some experiments with actual tests with plasma. Do all tests with plasma. Coagulation tests. Prothrombin time. Prothrombin time measured by adding tissue thromboplastin in the form of animal brain extract or recombinant equivalent and calcium to the patient's plasma. Normal prothrombin time 60-80 seconds. So what we are talking about? Let's repeat to this cascade. Okay, we have patients with bleeding disorder. We have patients who believe that something wrong with coagulation. But we have 13 factors. How to understand where is the problem? Which disease? To do this, we can do few tests. First, again, prothrombin time. Remember that we have few steps. First step, this is formation of thromboplastin, then prothrombin, thrombin, then fibrinogen, fibrin. Idea of such tests very simple. Okay, we know that blood coagulated longer than normal, something wrong. How to check what happened? First test, prothrombin time. We do what? We take patient's plasma, citrate plasma, and add to this citrate plasma calcium, because without calcium, no coagulation. And then we add a lot of thromboplastin. So first step of coagulation, this is formation of thromboplastin. And then what we do? We add thromboplastin, and then we see how soon coagulation happens. Normally 16-18 seconds. Just imagine, we add thromboplastin, and we find that prothrombin time normal. What does it mean? It means that problem was somewhere here. Problem was in formation of thromboplastin. All kinds of hemophilia. This is deficiency of 9, 10 factor of coagulation. This is problems of formation of thromboplastin. But prothrombin time in patients with hemophilia will be normal because we use external thromboplastin, and everything becomes normal. Then we can do thrombin time. Thrombin time, the same idea. Let's in this case add thrombin instead of thromboplastin, and then see what happens. If we add thrombin and everything okay, it means that something wrong was with prothrombin formation. If you add thrombin but still we have problems, only one way to explain: something wrong with fibrinogen. Something why for some reason fibrinogen can't change to fibrin. So this is the idea of such test. Let's add some factor of coagulation and see what happens. This way we can understand which level we have a problem. And again, prothrombin time 60-80 seconds, and prolonged with abnormalities of factors 7, 10, 5, 2, 1, liver disorders. So again, when patient experience problems with factors which produce thromboplastin during first step of coagulation. Next, thrombin time. I explained you, we add thrombin. Normally, thrombin time is 12 seconds, and prolonged with fibrinogen deficiency Why fibrinogen deficiency? Because again, we add thrombin, time higher than normal. Only one way, only one explanation. Something wrong with fibrinogen. Because already adding thrombin, we exclude all previous steps of coagulation. We give to plasma thrombin, but still some problems. It means that problem only in fibrinogen, lack of fibrinogen. Fibrinogen can change to fibrin. Next, activated partial thromboplastin time. Activation partial thromboplastin time. This is tests which tell us about generally about coagulation. That tell us about coagulation in general. No, APTT, also known this test, activated partial thromboplastin time. Performed by adding surface activators such as choline, phospholipid as a platelet substance, and calcium to patient plasma. Normally, APTT 30-50 seconds, depending on the extract methodology, on exact methodology, and prolonged with deficiencies of inhibitors. So just remember, APTT, or PTT, or PTTK, depending on actually methods which use, tell us about coagulation in general. Coagulation in general. And if we have some defects on first, second, third stage coagulation, this APTT time will be longer than normal. Normal, this is 30-50 seconds. You find that APTT higher than normal. Then you do thrombin test, prothrombin test, trying to understand which level we have a problem. And finally, actually, we can do so-called correction tests. Again, we have 13 factors of coagulation. That's why what we can do, just add these factors one by one and see what happened. If you add, for example, some 9 factor and coagulation time becomes normal, okay, this is deficiency of 9 factor. We detect what happens. All this known as correction tests. Okay, now let's talk about disorders. I told you that we have 3 components of bleeding stop. This is vessels, this is platelets, and this is coagulation. And it means that we expect to find out disorders of vessels, disorders of platelets, and disorders of coagulation system. All this may lead to bleeding. Okay, first, vascular disorders. Now, if to say briefly, this is disorders when vessels becomes fragile, when vessels easily broken, when vessels easily damaged, and it may cause bleeding, because if we have damage of vessels, just imagine this is pipes, vessels, pipes. If pipes for some reason damaged, okay, we have leakage. The same happened with blood. The damage of vessels cause leakage, and we see this as a bleeding. Again, we have a lot of vascular disorders. It may be congenital. No, for example, hereditary, so-called hereditary hemorrhagic telangiectasia, or Osler disease. It may be acquired, just some infections, for example, meningitis, meningococcal infection, presented with petechias on the skin. Those sepsis presented with petechia on the skin. It may be allergic disorders, for example, Hinoch-Shanlein or Shanlein-Hinoch purpura. It may be some drugs, for example, steroids may cause fragility of vessels and bleeding. It may be other causes, for example, senile purpura. You may see that in some elder people, you can see a lot of blue and black marks. It does mean that someone beat these elder people. This is just senile purpura, when actually elder people, they have fragile vessels and they're easy bruising. It may be easy bruising syndrome, when actually this is not even disease, this is just characteristic of vessels in some women. We see a lot of possible vascular disorders. Now, let's talk about each briefly. Hereditary hemorrhagic telangiectasia. Hereditary hemorrhagic telangiectasia is a rare disorder without autosomal dominant inheritance. Dilatation of capillaries and small arterioles produce characteristics small red spots that blanch on pressure in the skin and mucous membranes, particularly the nose and gastrointestinal tract. And recurrent epistaxis, this is nasal bleeding, chronic gastrointestinal bleedings are the major problems and may cause chronic iron deficiency anemia. So idea of this disease is very simple. We don't know why, but on some localization, for example, in patient's nose, we have specific dilated and very fragile vessels. And with small trauma, without trauma, these vessels just damaged, broken, and bleeding starts. And it may cause this source of bleeding, maybe nose, and patients suffer from periodical nasal bleeding, and it's caused epistaxis. Or if the same vessels presented somewhere in stomach or intestine, in this case, patient will suffer from continuous gastrointestinal bleedings. Actually, these bleedings are rarely very severe because vessels very small, and patient can't lose a lot of blood. But if it's happened continuously, every day, even loss of few milliliters of blood daily may lead to deficiency of iron and lead to appearance of iron deficiency anemia. And usually only one treatment, just use some surgical or some physical methods. For example, laser beam just to burn these vessels on this site, to coagulate these vessels, to prevent bleeding from these vessels. There are no other choice. In this case, we talk about hereditary hemorrhagic telangiectasia. Even name telangiectasia, angio vessel, tele multiple, ectasia distension. So this is multiple distension of vessels, multiple distension of the vessels, and which may cause bleeding. Easy bruising syndrome. Easy bruising syndrome, common benign disorder occurring in otherwise healthy women, characterized by bruises on the arms, legs, trunk, with minor trauma, possibly due to skin vessel fragility. It may give rise to the suspicion of a serious bleeding disorder. So we don't know why, but some women, they have weak and fragile vessels. And that's why even just you touch, you press, immediately in this site, you have some blue and black marks. What to do? No, nothing to do, because this is not serious. Bleeding never severe, no, just cosmetic defect. No, we just advise to such women, no, just be careful. And that's all. No specific treatment, no specific treatment. But you can say that this is benign easy bruising syndrome only if you exclude all other possible hematological problems, all other possible hematological disorders. Senile purpura, purpura due to steroids, both due to atrophy of the vascular supporting tissues. Again, in elderly people or in people who take actually steroids. This is hormones, glucocorticoids, for example, to treat severe asthma or rheumatoid arthritis. This leads to damage of vessels, collagen in vessels damaged, vessels becomes very weak as pipes, and easily leakage of blood happens. Presented the same, we can see also blue and black marks. For elder people, this is typical. And again, it's typical for people who take a lot of steroids to treat their other serious disorders. Purpura due to infections, mainly caused by damage of vascular endothelium, rush of meningococcal septicemia, particularly characteristic. So in some infectious disorders, immune system to fight with bacteria produce immune complexes to eliminate bacteria. But in some cases, these immune complexes, circulating, so-called circulating immune complexes, they may damage patient's own vessels, causing bleeding. And this is not even bleeding disease. This is sign of main disorder. And again, remember, if patients suffer from severe headache, especially if it's a child, severe headache, and you find on the skin petechial rashes, petechias on the skin, red spots on the skin, and again, severe headache. Don't forget, it may be meningitis, infection meningitis. Now we know how to treat infective meningitis. We just use antibiotics. We can just use antibiotics. But if you don't recognize this disease, if you just give paracetamol to treat headache, meningitis may be lethal. Cases when children die due to meningitis happen from time to time, and mostly due to underdiagnosing of this very serious disease. And again, headache typical for all people. But if headache plus rashes, petechial rashes, okay, this can be just benign condition. Don't forget about meningitis. Next, Hinoch-Shanlein or Shanlein-Hinoch purpura, occurs mainly in children. It's a hypersensitivity reaction that often preceded by an acute upper respiratory tract infection. Purpura is mainly seen on the legs and buttocks, and abdominal pain, arthritis, hematuria, glomerular nephritis also occur. Recovery usually spontaneous. Some patients develop renal failure. So what we're talking about? This is another disease. We call it allergic when we have some allergen, usually some infection. And immune system start working so hard that the immune system produce a lot of circulating antibodies or complexes, which start damaging not only bacteria, but they start damaging actually patient's own vessels. They deposited, they attach to vessels, cause inflammation, cause damage of vessels, and the result, we have vessels everywhere. If it's skin, we find actually specific rashes on the skin, If it's intestine, we'll find abdominal pain. If it's joints, vessels of joints, we find arthritis. If it's kidneys, because in kidneys we have a lot of vessels. Remember, what is glomerulus? Glomerulus is a huge number of vessels. And damage of vessels, remember that glomerular nephritis has the same mechanism. This is autoimmune infectious allergic disease. When antibodies produced by our immune system against bacteria may cause damage of our own vessels. The same mechanism. That's why clinically it may be as glomerular nephritis with protein in urine, with blood in urine. Usually for children, this disease recover spontaneously, even without treatment or disappear. Okay, next group of disorders. This is platelet disorders. Bleeding due to thrombocytopenia or abnormal platelet function is characterized by purpura and bleeding from mucous membranes. Bleeding is uncommon with platelet counts above 10 times 9 liter per liter, and severe spontaneous bleeding is unusual with platelet counts above 20 to 10 times 9 liters. So remember, normal numbers 150, 400. Usually bleeding starts when these numbers drop up to 50 or even 20, 10 times 9 per liter. This is stable, this is normal. 150 moderate hemorrhage after injury, 20-50 purpura may occur, 20 purpura common. Then spontaneous hemorrhage from nasal cavity and mucosal membranes may happen. So causes of thrombocytopenia, again a lot. It may be bone marrow failure. Again, thrombocytes produced by bone marrow, and all kinds of bone marrow damage or bone marrow failure may cause thrombocytopenia. It may be megaloblastic or B12 deficiency anemia. It may be leukemia, myeloma, myelofibrosis, some drugs, chemicals, viruses. So all what may cause damage of bone marrow may cause thrombocytopenia. Yeah? And remember, no, we will learn later that, for example, all types of leukosis cause bleeding. Why? Because leukosis cells occupy bone marrow. They don't let thrombocytes to be produced by megakaryocytes. As a result, we can expect bleeding disorder. Immune disorders. Again, many disorders with immune mechanisms. Autoimmune thrombocytopenia. First disease, autoimmune thrombocytopenia, very common condition. No, not very common, but rather common condition. Autoimmune thrombocytopenia, AITP. It may be hypersplenism, because you know one of functions of our spleen is to eliminate old and weak cells, like a filter. But if spleen becomes very big or with high function, it starts eliminating even normal cells. As a result, in case of big spleen, hypersplenism may cause thrombocytopenia. No, and some other actually conditions which also may cause decrease in number of thrombocytes. So, autoimmune, no, typical example of disorder which may cause thrombocytopenia. This is autoimmune, idiopathic, autoimmune, idiopathic. Why idiopathic? Means we don't know cause, without visible reason, idiopathic. Autoimmune, idiopathic, thrombocytopenic purpura. Autoimmune, idiopathic, thrombocytopenic purpura. Thrombocytopenia is due to immune destruction of platelets, again, autoimmune mechanism, antibody-coated platelets and removed following binding to Fc receptors on macrophages, two distinct linkers. Again, we don't know why, but immune system produce antibodies against platelets, autoimmune disease. Autoimmune, idiopathic, we don't know reason, thrombocytopenic purpura. Immune system produce antibodies against thrombocytes. Why? Nobody knows. Now, two clinical syndromes. Acute AITP, autoimmune idiopathic thrombocytopenic purpura. Usually seen in children, often following viral infection and acute development of platelet autoantibodies, probably responsible for the shortened platelet survival. Acute starts fast and then disappear. Again, nobody knows why. Usually this disappear and then disappear, and children usually recover completely, even sometimes without treatment. Chronic AITP, characteristically seen in adult women, usually idiopathic, who may occur in association with other autoimmune disorders such as thyroid disease, autoimmune hemolytic anemia, and after infections with viruses such as hepatitis, HIV virus, platelets, autoantibodies detected in about 60–70% of patients, presumed to be present, although not detectable in the remaining patients. So again, we have chronic autoimmune disease. Chronic means that it lasts for a long time and difficult to do something with this. No, actually, clinical features. No, major hemorrhage is rare, seen only in patients with severe thrombocytopenia. You see in all kinds of thrombocyte problems, we rarely see severe bleeding. Why? Because what thrombocytes do? Primary stop of bleeding. They just act during a few minutes. But in such patients, coagulation normal, and even bleeding starts, it's immediately stopped by coagulation. And that's why patient can't lose a lot of blood. No, easy bruising, purpura, epistaxis, menorrhagia, common. No, physical examination normal except for evidence of bleeding. No, splenomegaly is rare. Investigation. Blood count, thrombocytopenia, revealed thrombocytopenia, so low number of thrombocytes. normal or increased number of megakaryocytes found in bone marrow. Why? Because megakaryocytes try to produce more thrombocytes, but if they destroyed immediately, what megakaryocytes can do? No, detection of platelet antibodies is not essential for confirmation of the diagnosis, which often depends on exclusion of other causes of excessive destruction of platelets. Okay, final group of disorders, final group of bleeding disorders. This is coagulation disorders. This is when we have problems with coagulation. Coagulation disorders may be inherited or acquired. Inherited disorders, uncommon, usually involve deficiency of one factor only. Acquired disorders occur more frequently and almost always involve several coagulation factors. Inherited coagulation disorders. No inherited coagulation disorders, deficiencies of all factors have been described. Again, if you have factor, if you have some protein, this protein may be absent. No, just because of. And those leading to abnormal bleeding, typically those lead to abnormal bleeding are rare, but apart from hemophilia. So among all these coagulation disorders, typical and most common happens, this is hemophilia. Everyone knows about hemophilia. And hemophilia may be A, this is deficiency of 8 factor. Hemophilia B, this is deficiency of 9 factor. Maybe also we know about Willebrand's disease. So this is typical examples of inherited coagulation disorders. Inherited coagulation disorders. So hemophilia. Hemophilia, very interesting disease. Very interesting disease. From genetic point of view, what I mean, you know that only men suffer from hemophilia. Only men suffer. Why only men? Because the gene which in charge of production of 8 or 9 factor, localized in X chromosome. Localized in X chromosome. Women's, they have 2 X chromosomes. That's why even 1 X chromosome defect, another X chromosome normal, chance to have 2 defected chromosomes extremely low. And that's why women's never suffer, because they have 2nd chromosome and gene from this normal chromosome produce normal coagulation factors, no problems. But men's, they have only 1 X chromosome. And if this problem happened, if this defected gene happened, okay, no production of 8 or 9 factor of coagulation, no coagulation, bleeding disorder. Bleeding disorder. Very interesting genetic analysis. Very interesting genetic analysis. You know, if you ask patient about his relatives who suffer from hemophilia, you can find that his grandfather suffered from hemophilia. Grandfather. Why grandfather? No, it's easier to draw because, again, grandfather had this defected X chromosome. If he survived and if he had children, what happened? He gave his chromosome, but whom he can give his X chromosome? In case of boy, XY, XY. So what happened? What happened? Okay, this is a story about how actually this disease spread from generation to generation. Remember that actually it's spread in 2nd generation. And again, if patients suffer, only his grandfather suffered from hemophilia. And his mother was source of this defected gene. So in hemophilia A, the level of factor 8 reduced, but what else we can say? That practically it's never happened that gene present or absent. Usually we have some percentage of action. It means that, for example, normally gene is 100% acting and produce 100% of actually coagulation factors, for example, 8 or 9. Then it may be defected and produce 50%, 30%, some 10%, 2%, 1%. And that's why what we can see, that levels of less than 1%, just imagine 100 times less than normal, associated with frequent spontaneous bleeding from early life. And even in childhood, parents can see that his boy suffer from severe bleeding. In case of even small injury, hemarthrosis, hematoma. Hemarthrosis common may lead to joint deformity and crippling if inadequate treatment is not given. And some people with hemophilia, they use sticks to work because their joints completely destroyed. Bleeding into muscles also common. Intramuscular injections should be avoided. Just give intramuscular injections, and in this side you have accumulation of blood, because even such small damages used by a very small needle may cause damage and blood can't stop. You see, levels from 1 to 5% associated with severe bleeding following injury and occasional apparently spontaneous episodes. But if levels above 5%, mild disease, usually with bleeding only after injury or surgery. It should be noted that patients with mild hemophilia can still bleed badly once hemostasis has failed. The diagnosis in this group is often delayed until quite late in life. So what I'm trying to say, that extent of disease may be different. Maybe less severe, more severe, and based on this, I can say that for women with one defected X chromosome, level will be 50%, because two actually chromosomes produce 100%. If one defected, 50%. 50% more than enough, and nothing happened. Nothing happened. That's why women never suffer. Now, this is table to show what happened actually in case of hemophilia and so on. So if we talk about typical tests for actually hemophilia, okay, we have thrombocytopenia, we have vessels, and we have actually hemophilia. Remember, please, that bleeding time in hemophilia is normal. Why? Again, bleeding time depends on actually thrombocytes action. In hemophilia, thrombocytes action absolutely normal. Absolutely normal. Coagulation time, APTT, in patients with hemophilia increased because this is coagulation problem. But for patients with platelet problems, thrombocytopenia, APTT will be normal, because again, nothing wrong with coagulation. With vessels problems also will be normal. Okay, I understand that this is rather difficult topic. You know that we have a special doctors, hematologists, who deal with all such disorders. It's very complicated discipline. A lot of factors, coagulating factors, fibrinolytic system, anticoagulating factors, and to understand how all this work and how to treat. By the way, if we talk about hemophilia, now we know how to treat. We just give substitutional therapy. We collect blood from normal patients, not patients, people. They are donors. And we can now, we can actually extract coagulation factors, for example, 8 factor, 9 factor, and then patients with hemophilia, they just should take such remedies made from this donor's blood. In this case, they feel themselves more or less normal. Of course, it's expensive treatment, but for example, in our country, all this covered by the state, by the government. Okay, that's all about bleeding disorders. about bleeding disorders. Do you have questions? Guys, questions?
No. No, sir.
Okay,
No,
if
sir.
no questions, no questions, good luck and see you again in 2 weeks. Bye.
Okay, sir.
Bye, sir.
That's it.